We now move on our third talk for today, and it is my pleasure to introduce you Dr. Melanie Spears, Principal Research Scientist at the Ontario Institute for Cancer Research. The title of her talk is Assessing Immune Biomarkers of Response to Anthracyclines in Breast Cancer. Dr. Spears, the stage is yours.
So today I'm going to talk to you on the assessing immune biomarkers in response to anthracycline treatment in breast cancer. As most of you are aware, 1 in 8 women will develop breast cancer in their lifetime. In Canada, there was approximately 27,200 new cases diagnosed last year, and this accounts for 25% of new cancer diagnoses in females. There was approximately 5,000 breast cancer-related deaths in 2019. Breast cancer is made up of 4 subtypes: the luminal A, luminal B, triple negative, and HER2 positive. And treatments include surgery, radiation, chemotherapy, anti-hormone therapy, and targeted therapy. Today, I'm going to focus on the chemotherapy side of things. Chemotherapy in the form of polychemotherapy is used to treat high-risk breast cancer patients. Anthracyclines are a form of chemotherapy and has been shown to improve patient outcome compared to traditional CMF therapy. However, with the advent of anthracyclines, there's also side effects. And so they're considerably toxic side effects. And so it's important that we identify those patients who are going to respond to anthracycline therapy versus those who won't. There is evidence that suggests that chemotherapies such as anthracyclines are immunomodulating, and so primary immune response. Tumor-infiltrating lymphocytes have been shown to be associated with a better prognosis in triple negative and HER2 positive subtypes. In particular, in the neoadjuvant setting, TILs have been shown to predict for pathological complete response in response to anthracycline and taxane therapy. Whereas in the adjuvant setting, there are conflicting reports, and so the predictive value of pre-existing anti-tumor immune response isn't clear. Paper by Xuan Loy and colleagues showed that in triple negative phenotype, patients who had high TILs did significantly better in terms of disease-free survival compared to those that had the ER positive HER2 luminal subtype, and even those in the HER2 positive subtypes. When people have looked at the tumor microenvironment, they have used typical H&E slides. And so pathologists have looked at the TILs in that respect. And so there is a TIL working group that is deriving best methods and best practices for calculating TIL scores and scoring these slides. However, what the slides don't give us is the actual cell abundance and the makeup of the immune microenvironment. So it doesn't give us what the breakdown of each cell is there. And so with this in mind, our study looked at the predictive value of the immune biomarkers to anthracyclines in a breast cancer clinical trial called BR9601. Furthermore, we wished to examine the immune landscape in early breast cancer patients treated prior to their treatment of anthracycline therapy. The BR9601 clinical cohort was a phase 3 adjuvant clinical trial that was randomized into patients receiving either 4 rounds of epirubicin, followed by 4 rounds of CMF, or they were randomized to the second arm, which is 8 rounds of CMF. The trial originally recruited 384 patients, and we have clinical follow-up of approximately 12 years for these patients. It is important to note that these patients were all treated pre-Herceptin era. So the experimental outline was as such. The BR9601 clinical cohort was made into tissue microarrays, and we had 321 patients available. These were across 3 slides. We used NanoString's technology for access platform and used our immuno-oncology panel. The panel was derived of a module containing the immune cell profiling, a module containing the immune activation, immune cell typing, tumor profile, and the immuno-oncology drug targeting module. And then we selected ROIs based on tissue microenvironment versus the tumor. So the regions of interest that we were selected were based on the entire TMA core. So one tumor core contained 2 regions of interest. So the tumor mask was stained with a pan-cytokeratin antibody, and you can see this on the left-hand side. The mask below shows the white, which was the areas which are selected. The tumor microenvironment was selected based on the CD45, a pan-leukocyte antibody. And again, you can see below this, the white area denotes the marked area that was selected, the white area. This slide just gives you an overview of the type of cores that we were seeing. So the tissue microarray was generated back in the day when we first started the clinical trial. And so you can see those selected for tumor only. However, you can see that there's areas that have high infiltrates, as you can see in the bottom right-hand side here. And we have areas which have a lower immune infiltrate, but they're still present in the sort of top left here. So the actual DSP analysis. So as I said, originally the BR9601 recruited 374 patients. We made tissue microarrays from 321 patients, but the actual DSP expression analysis was performed on 256 patients. These were equally distributed in that 129 of those patients received epirubicin and 120 received CMF only. The first sort of analysis we did was we compared our DSP analysis with traditional immunohistochemistry, IHC. So on the left-hand side, you can see a plot that gives us Ki67 staining with IHC, and that's along the bottom x-axis. And then you can see the DSP tumor Ki67 staining on the y-axis. And here we see a correlation of 0.66. On the right-hand side, we have a correlation looking at HER2 expression. So again, on the x-axis, we can see IHC HER2 scores versus the tumor HER2 scores from the DSP. And here we have a correlation of 0.81. So within this analysis, we can see that there is significant correlation between the DSP and the IHC analyses. We also looked at predictive clustering by regions of interest morphology. And then you can see here that the tumor expression clustered together compared to the TME clustering in a different way, all denoting that the expression between the tumor and the tumor microenvironment can be very different. We then went on to look at the differential protein expression based on distant relapse-free survival. So this volcano plot gives you single protein expressions. In orange, we have protein expression in the tumor compartment, and in blue, we have protein expression based on the tumor microenvironment. And we looked at a false discovery rate of 10%. So within this analysis, we had 14 proteins that were statistically significant associated with distant relapse-free survival, and these included FFP alpha, B7H3, and CD8. Within the tumor microenvironment compartment, we had 13 proteins that were significantly associated with distant relapse-free survival, and these included fibronectin, FFP alpha again, and VSPA. We then went on to look at the correlation between the probes. And we were able to show that there was a large cluster of co-expressed immune proteins. There was a strong correlation between tumor T-cell markers with macrophages in the tumor microenvironment. There was also a negative correlation of stromal markers, such as fibronectin and EpCAM, in the tumor microenvironment with some of the immune proteins, such as B7H3 and CTLA4. We derived a T-cell score using the average expression of CD3 and CD4 and CD8. And we were able to say that there was a wealth of patients that had T-cell invasion. You can see this denoted in the red. We had patients where we see T-cells excluded. So there was T-cells present, but they did not invade into the tumor. And then we have an area where there's T-cell cold, as we expect to see in breast cancer. We also went on to show that proteins that were most associated with T-cell exclusion, so in this blue compartment, were fibronectin and B7H3. And here's the figures that show this. So high tumor T-cell scores were rarely occurred in the presence of high B7 or H3 or fibronectin in the tumor microenvironment, indicating this would be an interesting analysis to do some further analyses with. Furthermore, we then went on to look at some of the other important pathways and cell types expressions in the tumor microenvironment. So this volcano plot gives just hazard ratios, again, with the distance relapse-free survival. In the blue denotes the tumor microenvironment proteins or pathways. And then in the sort of maroon color, we give the proteins or the pathways that are in the tumor compartment. Within the tumor microenvironment, we saw the high expression of myeloid suppression, MHC2, apoptosis, and macrophages were associated with improved distant relapse-free survival. However, when we look at the tumor compartment, we can see that fibroblasts and checkpoint inhibitors are associated with a poorer relapse-free survival when we look at the tumor compartment. If we look at some of the single biomarkers as predictive or prognostic biomarkers, so these graphs show Kaplan-Meiers of survival with the distant relapse-free survival. So the top graph gives us the prognostic role of the EpCAM in the tumor microenvironment. Across the bottom, we have the time in years, and then we have the percentage of distant relapse-free survival. Blue denotes the patients that have low expression, and then red denotes the patients with high expression. And we can see that EpCAM, patients with a high EpCAM in the tumor microenvironment do worse compared to those with low expression. If you look at the bottom two Kaplan-Meiers, this looks at the predictive value of anthracyclines. So on the left-hand side, we can see patients that have lower marker expression. On the right-hand side, we have higher marker expression. The blue line denotes those patients that were treated with CMF versus the red line, which is patients treated with eCMF. And we can see that statistically, patients that had the high EpCAM and were treated with epirubicin did significantly better than those that were treated with the CMF only, indicating that this could be a potential predictive biomarker of anthracycline response. Some of the other ones that we looked at are FAP alpha in the tumor compartment as a potential biomarker. Again, the top Kaplan-Meier gives us the prognostic significance of this marker, and we can see that again, patients had low expression of FAP alpha did better compared to those with a higher expression. And again, we see that there is changes in those patients that have low marker expression with treated with epirubicin compared to CMF in the low marker and the high marker. But none of these are significantly significant. And finally, we looked at HLDR in the tumor microenvironment as a potential biomarker. Again, we can see that higher expression of HLDR improves the patient's outcome in response to prognostic, irrespective of treatment. Whereas if we look at the differences in the patients between treated with epirubicin and CMF, there was no significantly difference in these cohort. So in summary, DSP was successfully used to analyze a small clinical cohort of breast cancer patients. We saw differences in expression in the tumor compartment versus the tumor microenvironment. There was significantly differential expression of proteins identified, with 13 proteins in the tissue microenvironment and 14 proteins in the tumor compartment. Analysis of the pathways and cell types identified numerous pathways and cell types that were prognostic in this setting, and we have potential predictive biomarkers, including EpCAM and HLDR. And these are the people that have actually helped us perform this study.
Thank you, Dr. Spears, for a very nice talk. I have some questions for you too. Can you please comment why it is important to look at the role of the tumor microenvironment in the anthracycline response?
It's important to look at anthracyclines in the tumor microenvironment in that we know that some patients respond to anthracycline and some patients don't. As I said during my presentation, the use of anthracycline can be significantly toxic to these patients. And so we really need to identify a biomarker of response. So identifying those patients will respond and those patients don't. We've looked at the tumor microenvironment, the tumor now for a number of years. And so I think it's important to now look across the tumor microenvironment as we learn more and more about the area.
Thank you. What novel information did the genomics technology show that other technology couldn't achieve?
I think the DSP allowed us to look at across numerous proteins within one single slide. And so we're able to identify new and potential predictive biomarkers of response.
Thank you very much. How could this work be used in the preclinical setting?
Some of the work that we could be doing in the preclinical setting includes looking at some of these organoids and how the microenvironment plays a role in treatment response. And I think this is where we could use potentially the DSP technology.
Thank you. How could the results present here have an impact in the clinical setting?
I think the results here need to be validated, but I think with the DSP has the potential to identify new biomarkers that could be both proteomic and RNA, and they could be essentially then moved into the clinical aspect. The next steps for this study would be to validate any new findings and publish it. We also have other studies that we want to look at and look at the microenvironment and the role that it plays in breast cancer pathology.
Thank you again, Dr. Spears, for your presentation and discussion.